Tonsillitis and Quinsy. Things you will need when you're going to see a patient with tonsillitis or quinsy are head light, tongue depressor, blue spray or xylocaine spray, large bore needle and a 10 ml syringe, and scalpel and forceps in case of quinsy. For history, tonsillitis will present with prodromal period of 1 to 2 days, feeling generally unwell, pyrexic. They will have a sore throat, otynophagia, and difficulty swallowing. They can also have tender lymphadenopathy and otalgia, and some neck stiffness. With Quinsies, the presentation will start similarly, but they will also have a progressively increasing pain in the throat, usually unilateral, and a hot potato voice. In a patient with tonsillitis, you will find swollen erythematous tonsils that are likely to have some exudate on them. Neck palpation can show lymphadenopathy on one or both sides. Then investigations-wise, do an FBC, UNEs, LFT, CRP, and infectious mononucleosis screen. Deranged LFTs in an otherwise fit and well patient is a strong indicator for infectious mononucleosis even with a negative IM screen. So for your examination and documentation purposes, it's important to note the grade of tonsils. So grade 0 would be surgically removed, grade 1 tonsils hidden within the tonsillar pillars, grade 2 extending to the pillars, grade 3 extending past the pillars, and grade 4 tonsils extending to midline. In the case of quinsy, the patient will have trismus and will struggle to open their mouth. They will have unilateral pharyngeal bulge, and the tonsil will be pushed downward and medially. The uvula can look swollen and edematous and pushed to the opposite side. Neck palpation can show lymphadenopathy on one or both sides, and then sometimes patients can present with torticollis as well. If the patient is unable to swallow or is septic, you will have to admit them. Then primary management for both tonsillitis and quinsy are quite similar. So you need to get IV access, you need to give them stat dexamethasone, Difflam spray or mouthwash, and analgesia. Then for tonsillitis, you give IV benzyl penicillin, and in case of penicillin allergy, clarithromycin. In quinsy, the start is the same, but antibiotic-wise, you give benzyl penicillin and metronidazole, and if allergic to penicillin, clarithromycin and metronidazole. And the most important part is you need to aspirate or incise and drain the quinsy. To aspirate the quinsy, anesthetize the area first using blue spray or xylocaine spray. Attempt to aspirate the quinsy with a large bore needle. So insert the needle to the point of maximal swelling or slightly lateral to the point of junction of the anterior pillar with a line drawn through the base of uvula. If you do manage to aspirate some pus, consider incision and drainage. So you can use an 11 blade to make a small cut to the same point. Then insert forceps to break up the loculi. And leave the incision open to allow for further drainage and admit the patient. Patients that have 7 or more episodes of tonsillitis in 1 year, or 5 per year for 2 years, 3 per year for 3 years, and whom there is no other explanation for recurrent symptoms should be referred to ENT clinic for consideration of tonsillectomy. And patients that have 2 separate episodes of quinsy ever would benefit from tonsillectomy as well.